In the care of the trauma patient, which of the following statements is true? A. Care for the trauma patient begins from the moment they enter the trauma bay in the hospital. B. The primary survey of the ATLS protocol is based on ABCDE, which stands for airway, breathing, circulation, disability, and evaluation. C. If the patient's condition deteriorates, recheck everything starting with the airway. D. Hemorrhage is the only cause of shock in the trauma patient. E. All trauma patients except those with COPD get oxygen. The initial assessment and management of the trauma patient begins in the pre-hospital setting, so right from the beginning you know answer A is wrong. However, the ATLS course is focused primarily on the hospital setting, and so is this prep course. There are separate courses for pre-hospital personnel, and that information is not covered here. Those of us working in the hospital setting will coordinate with our pre-hospital EMS brothers and sisters during the patient handoff. The MIST template was developed to help standardize this handoff and decrease errors. MIST stands for mechanism, injury pattern, signs, and treatment given. The template will also include the patient demographics and other significant information like allergies, meds, and medical history. In the 10th edition, MIST is used to stimulate discussion, and you should get real comfortable with it because this is how your patient for the practical exam will be presented to you. You can read up on it in Appendix E, page 303 and 304. I'm going to use the MIST template a few times in this prep course to ensure that those of you who aren't familiar with it are comfortable with it before you take the ATLS certifying course. Chapter 1 is a general overview of the nuts and bolts of ATLS and the trauma protocol. ATLS provides a common language in the care of the trauma patient. In short, you have the primary survey, resuscitation, secondary survey, and definitive care. Of course, resuscitation is going on simultaneously with the primary survey, but the steps are taught sequentially so that even those who rarely see a trauma patient can successfully handle the initial management of any trauma patient. The goal is to be able to quickly stabilize the patient, identify and address all immediately life-threatening injuries, and if indicated, rapidly transfer to a higher level of care. If this seems a little basic for some of you, feel free to skip ahead. For those of you for whom trauma patients and all things trauma are completely new, this chapter is essential. As you may already know, managing a trauma patient is quite different from most non-trauma patients. Your non-trauma patient comes in, gets triaged by a nurse, the nurse gives you the patient summary, and you go see the patient, which could be minutes, an hour, or even longer after the patient came into the ER. The trauma patient, on the other hand, is seen right away by a team, which includes you, because he may be bleeding profusely, have a tension pneumothorax, or something else that will kill him quickly. Therefore, you need to have a completely different skill set and totally different mindset as well. Even in a small critical access facility that doesn't see trauma patients every day, you need to have a team of people who all have a role to play in the trauma bay. This may include a nurse or two from the floor that gets called over to the ED during traumas to assist. Each member of the team needs to be ready to receive the patient, ideally before they show up. And no matter how the facility you work at in real life divvies up the roles, for ATLS certification exam, you are considered the team leader. Bare minimum, your team should also have your best airway manager, which in a small hospital may also be you, a trauma nurse, and an additional person, whether a nurse or a tech. One of those people will also be doubling as the record keeper, and everyone should clearly say out loud what they have done. When it comes to the written exam, I can't stress this enough, you need to have the mindset that you are the team leader. You have to be able to see both the big picture and the details. Stay in that frame of mind. And for the practical exam, where you have one big scenario. You need to have the mindset that not only are you the team leader, but you're the whole team. This means that as you work up the patient, you need to mentally step through everyone's role and not assume things are being done, like they typically are in a real hospital setting where your nurses and techs are hooking the patient up to the monitor, putting on O2 and O2 stat monitors, starting IVs, etc. All this simultaneously while you're doing your evaluation. In the practical exam, if you don't say it was done, then it wasn't done. Don't think anything is insignificant, like saying we're taking universal precautions or 2 large bore peripheral IVs were placed. And please, touch the patient and go through the motions as if it is an actual patient. Not only will it help you remember what to do and say, but they may count it against you if you don't. Bottom line, don't be that guy that goes through the whole practical and fails because you forgot to say something simple, like you were taking universal precautions or that you placed 2 large bore IVs. Pay close attention to the section on how to prepare for the practical later in the course. As I mentioned in the introduction, the care of the trauma patient begins before she actually gets to the hospital. A vital part of the care is being prepared for whatever type of patient may arrive. There are 2 phases of preparation before the patient shows up: the pre-hospital phase and the hospital phase. Again, the pre-hospital phase and specific protocols for EMS aren't covered here. The main takeaway for you is to be sure that you get all the information possible from EMS when they bring the patient in. Don't count on getting any vital information from the patient because they may not be able to communicate due to their injuries. The hospital phase of preparation also begins before the patient gets there. You need to make sure that the trauma room is fully stocked and the equipment is functioning and checked routinely. Murphy's Law still applies. Anything that can go wrong will go wrong. And it can be something as simple as sticking a laryngoscope in the patient's mouth and it doesn't work because the light is blown. Another tip for your practical exam is to say nice and loud that the room was stocked and checked. Or a disgruntled instructor may tell you in the middle of your exam as you decide to intubate the patient that your laryngoscope is broken and the patient dies because you couldn't get a functioning one in time. Don't forget to protect yourself and your team. Everyone must take universal precautions: gowns, gloves, masks, etc. This includes decontamination for chemical burns and hazardous substances. Don't turn one patient into 3, 4, or more by having your team jump in unprotected. Your patient has finally arrived. He's transferred to the trauma bay bed and a paramedic gives you the handoff information. A 30-year-old, unrestrained male passenger involved in a head-on collision with an 18-wheeler was ejected from the vehicle. 1 death at the scene. An obvious deformity of the left leg and a large scalp laceration with active bleeding are observed. Heart rate 120, BP 98/60, respirations 30, GCS 7. 1 IV running LR, a C-collar, backboard, and LMA, and a bandage of the scalp wound were placed at the scene. Using the MISS template, you've gotten a good bit of information that should already have you thinking about possible life-threatening injuries and possible necessary interventions. M for mechanism. You have an unrestrained passenger in a head-on collision with an 18-wheeler who was ejected from the vehicle, and there was a death at the scene. Mechanism is very important, and paying attention to the mechanism may keep you from missing a severe injury in a patient that comes in with minor complaints and normal vitals. I. The known injuries reported to you by EMS include a large, actively bleeding scalp lac and deformity of the left leg, leading you to think about pelvic, femur, or tib-fib fractures. but obviously this patient is at high risk for multiple life-threatening injuries. S. The signs are all concerning, including the vital signs and GCS. Your patient is hypotensive and tachycardic, so you're already thinking about shock. T. And the treatments done at the scene include an LMA, which you know you will need to change out for a definitive airway, a C-collar, one IV, so he will at least need an additional IV placed, and his scalp was bandaged. Don't forget that scalp lacerations can bleed profusely, and a patient can go into shock from uncontrolled bleeding from a scalp lac. So at some point, you will have to make sure he is not exsanguinating into the bandages placed at the scene. All of this and more should be in your thoughts, but the ATLS protocol helps you to prioritize and address the issues in an organized and controlled fashion, and helps to diminish missed injuries. Don't yield to the temptation to touch the patient and start working until the handoff is completed. Once the handoff is completed, your primary survey begins, and the primary survey starts with your ABCDE. All of us who have taken any of the life support courses like BLS, ACLS, etc. are familiar with the ABCs. Similarly, in ATLS, ABCDE stands for airway, breathing, circulation, disability, and exposure. So answer B is clearly incorrect. E is for exposure, not evaluation. Memorize those until they are second nature. On the exam, they will be the foundation of your practical exam, and in real life, they are designed to ensure that whatever is going to kill him first gets addressed first. But before you jump into the full protocol, you should do a 10-second rapid assessment. Identify yourself, touch the patient, ask the patient's name, ask what happened. With the 10-second rapid assessment, you've got some basic and quick information on his airway, breathing, and level of consciousness. Now you're ready to begin the primary survey. A, B, C, D, E. A is for airway. Chapter 2 goes into more detail on airway and breathing. Don't forget to protect the C-spine at all times. In ATLS 10, the terminology has changed from immobilizing the C-spine to C-spine restriction, since we can't truly immobilize the C-spine manually or with a collar. But regardless of the terminology, the importance of C-spine protection remains. Quick tip on the practical exam. Remember to mention that you are protecting the C-spine when you're doing any airway manipulation. The airway should be reevaluated frequently, and if there's any deterioration in the patient's condition, then recheck everything starting with the airway. So C is the correct answer. Put oxygen on all trauma patients. Unlike many other patients that you may see in the ED, with trauma patients, wait and see is generally not a good approach. So err on the side of treatment, even with elderly patients with COPD. Everyone gets oxygen. Therefore, E is incorrect. If a patient comes in and you're concerned about inhalation injury, but the airway looks okay now, go ahead and intubate. Don't wait for deterioration. B is for breathing. This is your second priority after the airway, and they obviously go hand in hand. There can be no adequate ventilation without an adequate airway. But after the airway is secured, ventilation can still be inadequate for many reasons. Although difficult in a noisy trauma bay, it's still important to look, listen, and feel to detect major life-threatening chest or neck trauma early. Someone on your team should have hooked up the pulse ox and other monitors after the patient handoff. Of course, you are that someone on the practical exam, so don't forget to mention it. And like I mentioned before with airway, err on the side of treatment. For example, if you are truly concerned about tension pneumothorax in your patient, go ahead and needle decompress right away. Don't wait and see. If you find no thoracic source of hypoxemia, or if after treatment of a thoracic source, the patient is still hypoxic, go back and recheck the airway. Remember, don't be a dope. Dislodgement, obstruction, pneumothorax, and equipment failure are reasons for deterioration in an intubated patient. C is for circulation. Think bleeding here. Be aware of other potential causes of shock like cardiogenic and neurogenic shock, but for the most part, when your patient is in shock, he's bleeding to death. That being said, D is incorrect because there are other causes of shock in trauma patients. 2 large bore peripheral IVs should have been placed, and you'll hear me say this often, remember to say it on the practical. If you don't say it, it didn't happen. The key points in circulation are simultaneous, not consecutive. Volume, 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 and stop the bleeding. Start your fluid bolus, but think about giving blood early. In ATLS 10, there is an increased focus on giving blood early, and the amount of crystalloids recommended has decreased from 2 liters to 1 liter. After that, give blood. As you're giving your crystalloids, be thinking about blood, and as you're starting to give blood, be thinking about activating your massive transfusion protocol. Your goal is to maintain adequate end organ perfusion, not to normalize vitals. BP is not a good measure of tissue perfusion, but the shock index, heart rate over systolic blood pressure, can rapidly identify patients that need rapid resuscitation. If your patient's heart rate is higher than her BP, it's likely she will need blood, and get a Foley catheter placed early in patients in shock. Now, don't forget to check the back for a source of bleeding. Your rapid check for circulation includes these 3 components: level of consciousness, skin color, central pulse. When checking skin color, check the palms, not only on dark-skinned patients, but on all patients. Cool or blue fingertips may be your first sign of peripheral vasoconstriction. Your pulse check will often be femoral because your trauma patient will likely have a C-collar on, so you won't be able to easily get to the carotid. A major risk for trauma patients is coagulopathy, and ATLS 10 has added a new recommendation for tranexamic acid. It should be given within 3 hours of injury and may have already been given in the pre-hospital setting. Tranexamic acid is an antifibrinolytic agent that has been shown in the CRASH 2 trial to reduce the mortality from bleeding when given between 1 and 3 hours of injury. However, after 3 hours, it may actually increase the risk of fatal hemorrhage, so early administration is key with this intervention. After the initial bolus, a follow-up infusion should be given over 8 hours in the hospital. Don't forget to keep your patient warm to fight coagulopathy, and don't forget about coagulopathy in head injury patients. D is for disability. This is basically your neurological exam. You want to quickly check the pupils. Are they equal? Check if she's moving her extremities, and get a quick Glasgow Coma Scale score. In the secondary survey, you'll do a more complete neuro exam, but in the primary survey, the focus is the Glasgow Coma Scale. Most of you are probably already familiar with it, but for those who aren't, you'll find it on page 110. This is one of those things you just need to memorize. Make sure you have it memorized before you take the written test, and you'll likely need to know it for your practical exam as well. In ATLS 10, the scale has been revised, but don't worry if you already have the old scale memorized. You'll get the same score with the old and the revised scales. There is also a new focus on the Canadian C-spine rule and the nexus criteria to minimize unnecessary C-spine imaging. Review these prior to your exam. You can find them on page 139 and 140. Remember, if your patient has an altered level of consciousness, you should recheck the ABCs. Don't just assume it's from a head injury. E is for exposure and environmental control. You want to uncover everything so you can take a good look at what you're working with and not miss any injuries. At the same time, you know hypothermia is bad. You have coagulopathy and other evils to guard against. So warm everything. Warm the fluids, the blankets, and yes, even the room. Truth be told, we typically are in the room with an impervious gown, a lab coat, scrubs, cuddle duds, long johns, etc. And then you add in adrenaline, and we might not be the best judge of the temperature in the room. Suffice it to say that if you're comfortable, then the room is probably too cold for the patient. As part of exposure, don't forget to log roll your patient and check the back, where you might find additional injuries. This is also a good time to do your rectal exam and put in your Foley, OG, or NG tube if indicated and not already done. And remember, no NG or other tube in the nose if there's facial trauma until you have ruled out fractures of the cribriform plate. Once again, if you have any deterioration, recheck the ABCs. Resuscitation and treatment are covered separately in the book, but as you know, in reality, they're going on simultaneously with the ABCs. You don't wait until the end of the primary survey to start treatment. You treat each killer as you identify them. Some of the treatments, oxygen, blood, fluids, I've already mentioned. Your pulse ox, EKG monitoring, end-tidal CO2 in your intubated patients, and other appropriate monitoring should be taking place simultaneously. If your patient has a tension pneumothorax, needle decompress him right away. You can place your chest tube later. If she has cardiac tamponade, do your pericardiocentesis right then. Time is of the essence in trauma patients. Delay costs lives. Get your FAST or DPL, chest x-ray, pelvic x-ray, and any other emergent imaging that would be appropriate at this point. The timing will vary based on injury, but by the end of your primary survey and before your secondary survey, you should get your emergent imaging. Key point for your practical exam, written exam, and real life. Think about transfer early on. Don't wait on scans or other images. If you've already identified problems you know your facility can handle, call for transport. The secondary survey starts once your patient is stabilized. Now it's time for you to get a complete history and do a more thorough exam. You should use AMPLE to gather the information you need for trauma cases. AMPLE stands for allergies, medications, past illnesses and pregnancies, last meal, environment, and events. Keep in mind the importance of the mechanism of injury in raising your suspicion for specific injuries, especially injuries that are easily missed. Take a look at page 14 to review typical injury patterns and mechanisms. In the secondary survey, you also need to do a full head-to-toe exam. Look, listen, and feel everything, and get your non-emergent diagnostic studies. But again, if you're planning to transfer the patient, don't wait for a full set of x-rays and scans. Your patient should be reevaluated constantly. In addition, if there are any changes in the patient's condition, or if EMS, police, or family members give you additional information, be sure to reevaluate the patient with the most current information you have in mind. If there is any deterioration, reevaluate, starting with the A of your ABCs. It may seem obvious, but once your primary and secondary surveys are completed, you've got 3 options. You can transfer the patient, you can provide definitive care in your facility, or you can discharge the patient home. Pick the one that will yield the best outcome for the patient. As I mentioned earlier, the ATLS 10th edition protocol has an increased emphasis on teamwork, and part of your team is the record keeper. This is an important role. Many of the procedures done in a trauma setting, like intubation, chest tubes, and cricothyroidotomies, are life-saving emergency procedures. You're not going to get consent beforehand in these situations. So even if you're in a small facility where you don't have enough staff to have a designated record keeper, keep in mind that your records need to document what you have done and that these procedures were truly emergent. Good records are also critical for the patient who is being transferred to another facility for definitive care. They need to be able to rapidly determine what you found and what you did. Of course, this should be told to the accepting physician, but the details need to be well documented in the record that goes with the patient.